Hi, thank you for inviting me to this presentation. My name is Virginia Abello. I work in Colombia en la Fundación CTIC, Luis Carlos Sarmiento Angulo, para investigación del cáncer y tratamiento del cáncer. I'm going to talk a little bit about the management of advanced phases in chronic myeloid leukemia, especially focusing in perspective from emerging regions. The CML status right now has changed dramatically, as we all know, for chronic phase patients, but sometimes for advanced stages, which is at the accelerated phases and blastic phase, this is not the same. This is not the case. Remember, just a little note that we won't talk about accelerated phase after the last actualization of the WHO classification. Right now we talk only of two phases, chronic phase and blastic phase, but for the purposes of this information, we will talk about also accelerated phase because we recollected this information before this. The better survivals in most countries worldwide has become also a burden of the disease because there's a stable population growth in developing countries, and there's a population aging also, which comes with more chronic myeloid leukemia, of course. Unfortunately, in Andean region, Latin American Andean region, Central Africa, South Africa, and Western Africa, which are low socio-demographic index, there's a fastest growth in incidence cases, the deaths and disability. Adjusted death rates showed significant decrease in trends in most geographical regions, except in Central South Africa, and actually in Ethiopia, it has been higher than expected. If you see this chart from 195 countries done in, this is a research done in 2017, we see there's a lot of course, as high of the population of a country. For example, India has 5,300 deaths and a yearly due to chronic myeloid leukemia. But when you adjust for the population and the age, actually the death rates are very high in places like Ethiopia, Honduras, and if you see the rest of the world, it's around lower than 0.5. So TKIs have had a profound impact in the improvement of survival, but in low middle income countries, this is not the same. What has happened here in low middle income countries that the introduction in imatinib and other TKIs have been more gradual. There's difficulty accessing TKI therapy due to high cost of medication. And we did this research in 2021 with friends from Latin America, and what we found is a very busy slide, but we basically what we find is there's significant difference between private and public systems in Latin America. You can see there in first line, most patients in public system has only imatinib, whereas in private settings in Latin America, we have most of the TKIs available. There's a little availability to ponatinib, for example, in Latin America at this time. And again, for second line, we have a lot of difference between countries, between systems in the same country, and the access to transplantation is limited. In some countries still, we still have mixed, complex, underfunded, and several subsystems between systems in the same countries, which makes the evidence and the access to TKIs very heterogeneous. And we prove this actually in this analysis. We have in Colombia, we have a registry, hematological diseases registry, and we have been collecting information on chronic myeloid leukemia in the country since 2018. And we can see this is an analysis we did when we have 357 patients, and what we're showing here is the progression-free survival is very different statistically different between patients in the contributory system, which is in Colombia, people that work and has contributed to the system, you know, and it's very different from patients that are in the subsidized system, which is in Colombia, it's the public system. So this is the characteristic of the patient, and basically showing that it happens all over Latin America, that we have different systems in between a country. There's also delay in therapy. This is from Bosnia, actually showing how patients having 5 months, 0 to 5 months in delay in starting therapy. Of course, they achieve a good cytogenetic response, while patients having more than 13 months to start therapy had worst outcomes. The same for the rate of molecular response. This is from Bosnia, published in 2016. Also, the monitoring is challenging. This is a little old. I think this has this is better now, but this is from Dr. Cortez in 2010. And as you can see, the access to PCR at that time was only 60%, which is very low. FISH PCR mutations low. I think this is still the case. We cannot, in most Latin America, we cannot test for FISH or mutations. PCR has improved, but not as good as we have. And especially regarding the PCRs, the quality of them is not heterogeneous. Also, there's things relating to the general population health systems. For example, there's still in low middle income countries, there's still a lot of smokers, which has been associated with deaths in chronic leukemia. And also, for example, in low middle income countries, there's still a lot of higher deaths in females than males, which it reflects the opportunity of screening and treatment, which is, it reflects in how the health systems in our countries work. Also, when we talk about advanced phases, if you see the CNN guidelines for accelerated phase of blast phase, the first treatment recommended in the guidelines are clinical treatment, clinical trials. Why? Because we don't do good whatever we have. But if we see, this is a report on how the researchers, the number of researchers in the world are, and as you can see, the percentage of researchers and FDA regulated studies are mostly in Europe and Northern and Western Europe. So in North America and Western Europe is the majority of the investigation in the field. So we don't have access to this first recommendation we clearly need. 50% of studies presented to the FDA are producing in the States. 70% of the 75.6% of the clinical trials take place in USA, Canada, or Holland. 83% of the research takes place in Europe or America. So low middle income countries, we don't have access to clinical trials. The access to clinical trials is really limited in most of Latin America and most of low middle income countries. Also, when you see the guidelines, most of these patients that are in blast phase, for example, should go to transplant. Also, accelerated phase, when they don't respond, they should go to transplant, which is the only curative strategy for these patients. And this is the picture, how it looks in our countries. Unfortunately, this is transplant rate in Europe in 2018. And as you can see, rate of transplants in Europe are around 300 to 400. While this is a picture what happens in Latin America, this was published in 2020, but it represents the number of transplants per million inhabitants in Latin America in the year 2017. So as you can see, only Uruguay, it's the same rates as Europe. All of the other countries are very, very far away from that. Argentina is a little better. And this is the result of this study. Only 6% of the 28 countries in Latin America have established transplant programs. So there's, to begin, we don't have transplant in all countries. It has the number of countries have been increasing every year, but we're still very, very far away from Europe or the States. The median transplant rate was 58, 30%, 13 in Venezuela, to 346 in Uruguay. And as you can see, we're really far away from other countries. There's a huge inequalities in Latin America, and this has been measured all around. And so what it means is, if you're in a country, you will have different opportunities to get to transplant, very different. There's a lot of inequalities in Latin America. The access to unrelated transplantation is limited in Latin America also. There's no local registry in most countries. There's low density transplant teams, and there's intra-country geographic distribution transplant centers. For example, in Colombia, 80% of the centers are in the center of the country. So if you take the coast or the Los Llanos Orientales, you won't have access there. And well, we're really convinced in Colombia that we have to show our results. We have to measure what we do. So we established this registry. This is RENEOC, which is our national registry. We have been working from May 2018. Here it's how the number of investigators and centers are growing. This is a NACHO, which is a National Association of Hematology Oncology research, and this is the distribution of the centers. We have 2,561 patients including right now, which are distributed between chronic myeloid leukemia, myeloma multiple myeloma, and acute myeloid leukemia. But we're growing each day, and we plan to register all our diseases, at least our malignant diseases, and also aplastic anemia. We're going to enter. This is our information from for our patients right now. The last evaluation we did, we have already 668 patients. This is the characteristic of the whole population. As you can see, we have a lot of patients. It's a retrospective registry mostly, so we still have a lot of information missing. But there's a high, intermediate, high so-called groups, and we mostly 60% of the patients treated in first line with imatinib, and from those patients, 7.4 patients debuted in accelerated phase or blastic phase. We're classified as that. If you compare this with international registry data, France is lower, Slovakia 7%, Turkey 5%. So we're quite similar. That the registry is a little less than Italy and Europe, but lower than Mexico. Which is very high. And from our 60, perdón, voy a hacer esta diapositiva de nuevo porque me quedo todo mal. Okay. So this is the data or our last analysis. We have registered right now 668 patients in the different centers in the country. So this is the information of this patient. Of those, 7.4 patients debuted in advanced phase. And 24 patients progressed to accelerated phase at any time, and 18 patients progressed to blast phase at any time. So the total progression rate to accelerated phase or blastic phase was 6.8. The incidence progression, it has been lower in most countries right now. It has decreased to 1.5 to 3.7 if you use imatinib. And if you see the data, for SND, it's lower for orinotinib, also lower for dasatinib and lower for bosutinib. In the Swedish registry, the cumulative incidence was 4.3, so we're a little upper than that, than the registries and the international information, but not so bad. We have 26 patients that progressed to first line, 10 patients that progressed on the second line, and 6 patients that progressed on the third line. And most of the patients that progressed in imatinib. 40% of the patients were treated with imatinib when they progressed. And especially patients that progressed in the first line, 65% of them were treating with imatinib in first line. The median time progression was 66 months. And this is the comparison between our patients in the whole cohort and the patients in the blastic and accelerated phase. The 88 patients that were either diagnosed or debuted in accelerated phase on blast phase. And as you can see, it's very similar to the whole cohort of patients. Most patients, the most frequently used TKI in Colombia still is imatinib, 60% of them. But we have a quite few numbers of patients treated with dasatinib and imatinib and nilotinib also. And this is very important for us. We try to find out what happened with adherence to treatment, which is very important for results in this patient. As you can see, we have 40% almost patients in first line that had reported at least one interruption. 23% of patients presented more than 23% of patients reported more than 2 interruptions at any times. 2 interruptions for 2.3 patients. 14% of patients had 1 interruption. And for second line, the same. Around 40% of patients had problem with access, and it represents interruptions in the treatment. And since this is a retrospective registry, this is what happens. We have lost a lot of information about patients, about the results. So, but from what we know, 60% almost did hematological response, 48% had cytogenic response, and major molecular response, 30% of patients. So this is the status at last visit. The median follow-up of the whole cohort was 63 months. And as you can see, most of the patients, 80% of patients are alive, 20% of patients died. So that's a thing. There's patients in major molecular response and complete hematological response. So the median survival is around 80% for these patients. And what we did was to compare what happens if you have a accelerated phase or blastic phase. And as you can be expected, patients in blastic phase did worst. The mortality rate was 27%. The median survival was 39 months. In comparison with accelerated phase, that mortality rate was lower, and survival was 69 months. This is a good data because it represents the efficacy of TKIs in our patients. But of course, we need to do a lot better, and especially in these blast phase patients, to notice we have a good access to transplant in Colombia, but none of these patients achieved transplantation, were taken to transplantation. This is due, as I told you, because we have a concentration of transplant centers in the center of the country. So we clearly have to make these patients go to transplant, especially those patients in blast phases. So in emerging regions, blastic phase and chronic and accelerated phase continue to be a challenge, even in 2023, in the whole world, but especially in these emerging regions. The situation is worsened by local situation. The access to third generation TKIs may be limited. And as you saw in the chart in Latin America, this is the case in most countries. The clinical trials are limited. Access to transplant also is limited, but also mostly is more than limited, is inequitable. Local information is lacking in most countries. That's why our information becomes important in RENEOC. This is an immature registry also, but we hope we can mature this information to develop new questions for investigation in the region. The optical management of these patients represents, the chronic phase represents the best way to avoid disease progression. And this must be our primary goal. And there's much more for improvement, especially in our regions. So it has been a pleasure. I hope you enjoyed this information, and I will be waiting for questions if needed. Thank you.